Hello everybody, my name is Mohammed Ahmed. I'll be discussing one of the most high concept in USMLE Step 1 exam. Let's start. 53-year-old male is brought to the emergency after being involved in RTA. The patient was found unresponsive. He was intubated. On arrival, the blood pressure is low and the patient pulse is high. The patient is shocked. He's intubated and mechanically ventilated. So I'm thinking of two main types of shock. Like the first thing come to my mind, the first thing is hypovolemic shock. Hypovolemic shock actually can be caused by multiple causes, as in gastroenteritis settings caused by severe vomiting or severe diarrhea, can be caused by hemorrhage, as in traumatic settings. Hemorrhage can be differentiated into two main causes in trauma. The first thing is intra-abdominal hemorrhage, which will be detected by e-fast examination, and the second cause is long bone fractures, as in femur or pelvic bone fracture, which will cause severe bleeding up to 2 liters. Okay, the first thing comes to my mind is obstructive shock. Obstructive shock can be caused by multiple causes too. So the first thing comes to my mind is pulmonary embolism. However, in traumatic settings, you shall think of tension pneumothorax. And tension pneumothorax can be excluded by chest examination, as the tension pneumothorax will present with tracheal deviation to the opposite side and decreased air entry in the affected side, and tympanic percussion on the affected side. Actually, tension pneumothorax is some sort of air in the pleural space surrounding the lung, make it impossible for the lung to move. So it pushes the lung to the other side, pushes the trachea to the other side, makes it hard to breathe. However, the patient breath sounds are present and equal bilateral, and trachea is midline, so it's not tension pneumothorax. And central venous catheter is placed for fluid, and CVB is elevated, and it got worse after giving 2 liters of blood. So patient with high CVB and got worse with normal saline, you shall think of cardiogenic shock. And cardiogenic shock actually can be caused by two main causes. The first cause is myocardial infarction, which will present usually as typical chest pain, which a lot of criteria, but it's not the case here. The second cause is blunt cardiac injury, which can cause myocardial contusion, some sort of trauma to the heart affecting the heart functionality. So the heart cannot pump any blood any further to the systemic circulation, so the blood got congested in the systemic circulation, which will cause some sort of CVB or jugular venous distension. And after giving the fluid, the patient heart cannot pump any blood any further, so it will get worse, and the patient will get congested more and more, so the CVB will be elevated. So like the bottom line here, any patient presenting with elevated CVB with shock, and the CVB is getting more elevated after giving fluid, it's likely cardiogenic shock. However, let's look at the choice answers. Anaphylactic shock. Anaphylactic shock, which usually comes after like peanut eating or having some sort of drugs, will have some systemic and mucosal and skin manifestations like wheals and some sort of acute urticarial reaction. Anaphylactic shock will present with hypotension and tachycardia. Hypotension, of course, due to severe histamine and inflammatory mediators releasing, and patient will have reduced CVB because the patient is not congested, the patient is collapsing. All the blood is in systemic circulation, the blood is pulled in the periphery. Okay, of course, the treatment is epinephrine. IM epinephrine. Usually, we start with one dose, and we can repeat it up to 3 times. And of course, intramuscular epinephrine is superior to IV epinephrine, which will be discussed in step 2 in detail. Blunt cardiac injury is the right answer. Hypovolemia, we discussed it, but hypovolemia will present with low CVB, and of course it will get better after giving some saline because we are replacing the lost fluid. Okay, intracranial hemorrhage will present with some sort of increased intracranial pressure manifestation as hemorrhage, blurred vision. Spinal cord injury caused neurogenic shock. Neurogenic shock, of course, will present with low CVB because the loss of sympathetic tone over the blood vessels, which will cause severe vasodilation. Actually, it will be looking some sort of anaphylactic shock, of course, without the skin and mucosal involvement. Tension pneumothorax, we can exclude it easily during the chest examination as told before. So the take-home message here, if you're having some sort of elevated CVB, will be looking into cardiogenic shock or obstructive shock. Cardiogenic shock will be MI or myocardial contusion. Obstructive shock will be caused by pneumothorax or pulmonary embolism, of course. However, it can be excluded by chest examination, and the cardiogenic shock will get worse after giving normal saline. Thank you.